Welcome, everybody. Good afternoon, good morning from wherever you are connecting from. Thanks for joining this UICC virtual dialogue today. My name is Alessandro Di Capua. I'm the Senior Manager for Leadership Development here at UICC, and I will be your host today. So thanks for coming. So as we wait for people slowly to join the virtual room, you'll be happy to know that this slide that you're seeing is the only slide you will see today. This is a dialogue, this is a conversation. We'd like to involve all of you, of course. And so we're not going to go through slides, but we just wanted to start this virtual dialogues with the nice smile of Christian that you can see here in the photo. So for those of you that, I know there might be people who may have not have attended a virtual dialogue before, just a quick word. This is a platform that UICC has started since 2 years, since the pandemic sort of stopped all our in-person connections. And they are pretty much, as they say, the dialogue where we're trying to bring together the cancer community around some themes. This particular series that we're starting today is the Leading Question series, is around as the title says, around leadership, which is an important theme for UICC and the cancer community. And it tries to address leadership themes, emerging leadership demands that hopefully will be relevant to all of you, regardless of your title and your areas of work. So as I said, this will be a conversations. You all welcome to switch on your video if your connection allows. And there will be time in which we will look for your perspective and your comments. So hopefully you'll be eager to engage with the conversation. So let me stop. As I said, this is the only slide that we'll be doing. So let me stop there and see a little bit. We got a few people in the room already. So as I said, today we'll be discussing the cultural dimensions of leadership. And we're going to have with us our guest, Christian Ntizimira, which I'll introduce in a second. But because we're talking about cultural dimensions of leadership, I think it'll be quite interesting to see where many of you come from, where you are connecting from, to have a little bit of a map of the world where you are connecting. So we'll try to do this in a slightly different way. So I will soon post in the chat box a link to that you will follow, where you can pin your location on a map, and I'll briefly show you how you can do that. Give me a second. So the link will take you to this map. Let me move my faces, and as on the top right you will see a plus button where you can simply enter the location where you are connecting from. I am based in Geneva, in the Secretariat of the Union for International Cancer Control. So I'm just going to select that and publish my location. So there we are. And it'll be great if you can all pin your location on this map. So we might come back to it later, have a little look where you are. In the meantime, I ask my colleague, Sinead, to post on the chat box the link where you can add your location, simply added by using the plus sign on the top right. So I'm going to stop sharing. I can see some people connecting. You will be able to add your location while continuing listening to us, and we'll come back to the map a little later. So now, without any further ado, let me introduce our guest who will guide us, help us grapple with some of these issues today. We have the pleasure to have with us a longtime friend of UICC, Dr. Christian Ntizimira. Let me give you a little introduction to Christian, for those who don't know him. So Christian is the founder and executive director of the African Center for Research on End-of-Life Care, ACREOL, in Rwanda. Among many things, Christian is a Fulbright alumnus and graduated from Harvard Medical School at the Department of Global Health and Social Medicine, and is the former executive director of the Rwanda Palliative Care and Hospice Organizations, which is a non-profit organization focused in home-based care in the city of Kigali. He was also named a young leader by the Union for International Cancer Control in 2016, and a distinguished young leader by the Harvard Global Health Catalyst in 2017. And most recently, in 2021, he was awarded the Thalberg Eliasson Global Leadership Prize in the Emerging Leader category. So you can see, just recently, they finally dropped the young description from your prizes, but it's good to see that they've kept the leader tag. So welcome, Christian. It's great to have you today.
Thank you, Alessandro, and thank you, the USCC community, to inviting me for this discussion. I think it's more a dialogue than an interview, and I'm also here to learn, sharing experiences, but also learn from my colleagues or participants who are here to build a what I call a global community. And then palliative care or cancer care, control, treatment, and supportive care. Yeah. So thank you for welcoming me.
Thank you, Christian. So obviously, this today we will be looking to discuss a little bit, as the title says, the cultural dimensions of leadership. However, the best way to start to do that would be to start drawing from concrete example and from your work. So maybe we should start a little bit from your work in palliative care in Rwanda, Christian. So I think it's been roughly more than 10 years when the Ministry of Health in Rwanda set a goal for universal access to palliative care. So how did you get to engage with those efforts, and what progress has been made to date?
Thanks, Alessandro. I think my experiences was, I can say, bizarre, because in the beginning, my dream was to be a surgeon, not a palliative care physician, until I faced a very sad story when I saw a young patient who was really dying with a liver cancer. It was advanced stage. And to see his mom came to me and kneel before me and request something can help his son was a turning point of my professional career, because I came with this idea to be a surgeon, to support the country, building the country after the genocide against the Tutsi. Then I just realized my position and my perspective of care changed completely, because that story changed my way of thinking. And since then, I decided to really focus on palliative care when I've been trained. And the government, since the government was really involved by launching the national palliative care policy strategic plan for 4 years, and now integrating palliative care in Rwanda health system, was, I think, the game change to bring palliative care in another dimension, where community and patient are the first, not a physician, as we use, to be trained that physician is the one, but I think it's the community who is the one. So since there is a lot of progress, even if the challenges is everywhere, but I think the most important thing is every step we are doing in our progress.
Thank you. And so obviously, we know from other countries and other examples that are real challenges, particularly around sorts of access to palliative care, and those challenges can be coming from belief, a certain understanding from the physician community, from the patient's community about what palliative care is. A perception that is always linked to end of life. How do you think, what were the key success factors that enabled Rwanda to be such a pioneer, let's say, in enabling access to palliative care for the whole population?
I think, from my experiences, is the government is focused on the populations. So it's first to listen to the community, because sometimes we came with the idea that we have all solutions, and we put all solutions on policies, and we ask people to implement. And in Rwanda, it's in different ways. We ask first the community what is the challenges and what they think about the solutions, and then from there, policymaker, decision makers, they now working to bring, to frame all those solutions on the way it was described by the community. And that is, I think, the best way to solve, some of the challenges, instead of just develop a document on some places and send it to people and say, oh, this is the document, go and implement. Sometimes it doesn't work, on that way. Yes, and I think my own experiences is, I have to be honest, I made many mistakes when I was starting doing palliative care in Kibagabaga, because I was trained in the US. It was a fellowship program, and I was so impressed by the palliative care in the US. Then I came back home and tried to duplicate the same model I've learned from US. And it was a nightmare. And I conflicting with the patient, I conflict with the family members, and I questioned myself, why it doesn't work? What was the problem? Because I thought on my side that the education and the skills and knowledge I gained from US was really, really important and critical to bring change. But I forgot a little element on my implementation, is the context. The context matters. Context matters. And then I just realized that education doesn't mean duplication, but rather than adaptation. So if you are well educated abroad, please try to adapt what you gain outside to the local context, instead of just to come and duplicate the same model, because that will conflict, your community, that will conflict the patient. And I had to stop for a few months and rethink what will be the best model of palliative care, or what will be the best services I can give to my patients and family members. Then I just realized that culture matters. I need to bring another dimension of culture in palliative care. And since then, I have a less and less conflict and less challenges, because at the end of the day, you have the support from the communities.
I think this element of that you raised before, to starting with the community, it's a very key one, and something that we will come back. You mentioned, even if you have the best guidelines, if they are not embraced and adopted by the community and owned by the community in a way that's meaningful to them, it doesn't matter that you have the best guidelines in a piece of paper. I wonder if you could just elaborate a little bit more on, after this reflection that you said, after you're coming and seeing that you couldn't simply turn what you learn in the US and apply it to Rwanda's settings. What was your approach? How did you approach palliative care after this method of reflection? What changed in your approach?
Yeah, so I came with a different approach, and one of the approach, I call it, because it came from experiences. One of the most experiences was the patient autonomy. I've learned from, it's an example, I've learned from US how strong patient autonomy is, when, the patient can decide who was to be on board and who, can be involved on the management of the patient. But in most of African countries, there is a similarity when there is engagement of the community. So then I've learned from my experiences in Rwanda social context, there is a saying that when you are well, you belong to yourself, but when you are sick, you belong to your family. So then I brought this approach to me. I call it a butterfly approach. I don't know why I'm choosing a butterfly. When you have on left wing, you have the patient autonomy, and in right wing, you have the community responsibility. So it's not one way split other. It's how you can use the intersection between the patient autonomy and the community responsibility, because this is how the context works here in Rwanda, and I think in most African countries, the community is really involved, and you can say that, oh, the patients, you know, because the community has involved on paying the bills, feeding the patient, you know, and the whole psycho, social, and spiritual support. Instead of saying, oh, we just need what the patient say and the rest we will cancel. No, it's how it can work in one side, in the US, in Europe, it's because this is the culture is in US, but in our culture and in our settings here, you will see the engagement of the community. So we can neglect that if you need to support the patient. So I came with that different approach and try to learn very simple things. You know, let's say an example in terms of personhood. You know, in the US, you have a privacy, individualism. And I remember my first trip in the US was very funny because I learned people saying, you know, some, I think the word was person space. I didn't know what this person space means, you know, because in it wasn't clear in my mind what is person space, you know, and those simple things when you have our community approach here. So it was really important to see how we can adapt. But before to adapt, we need to adopt, because it's difficult to adapt something if you don't adopt with the existing practice and the existing perceptions. So first is to adopt, second is to adapt. But most of the time we say we need to adapt, adaptation, but adaptation is the second step after adopting what is really existing, what is the perception. Then on using those perceptions based on the challenges and also based on the solution will be the solution proposed versus the existing solution the local level, and try now to merge. So first I had to adopt, then I had to adapt as well.
Yeah, so that's, and again, it's I suppose what we sort of trying to, one of the key point is obviously there are key and best practices around that you were trained in the US and you learn. It's about how do you implement them on the ground when you have to deal with a culture there, where, as you said, there is the community matters when it is about for patients' choices and decision. You have to deal not just with the patients, that might happen in a more individualistic culture that we could generalize as the Western being more, but you have to deal with the family, with the community. And I remember in some other talks, and listen, you discussed this sort of approach with the terms of decolonizing palliative care. So yeah. How would you describe that?
Yeah, I think decolonizing palliative care, especially end-of-life care, it's really important because the perception of end-of-life care differ from one side of the world to another side of the world. And on my definition of decolonizing end-of-life care is more about taking into account some critical elements in the local context, because that is really important. I'm not using the anthropologic way of deconstruction and the construction. No, I'm really thinking in sense of a constructive, where some element is really important from one side of the world, and those elements, if it's neglected, could bring inequity and social injustice, even if you are focused on management, on the care of the patient. So on that sense, decolonizing its end-of-life care is really important on the sense, on a very constructive way, when we all those elements, first is to listen, from the ground, to listen from the community, to listen from the patient, to listen from the family. What is really important for them? Yeah. What is the key point? Because we need to understand that from my research, that the traditional palliative care existed before the modern palliative care exists. So in pre-colonial period, palliative care existed, but it was not called palliative care. It was called maybe something else in my mother tongue, or maybe in Swahili, or in other tongue. But palliative care, traditional palliative care existed before modern palliative care exists. So, and the solution was using that time was relevant at that period of the time. So, and there is a lesson learned we can use from that period, and see how now we combine with a modern approach and try to create a synergy which can support, the community, support the patient, and also support the system as well. So it's really important, on my understanding and my opinion, that to take into account those critical elements, which is really valued in the society of the patients and the community. Yeah.
Thanks, Christian. And I'm just quickly looking at the chat box, and there are some comments, and I wonder if we can extrapolate some. There's Dr. Raj Kumar, who's commenting in the chat that he's involved in cervical cancer screening and HPV awareness programs in the rural areas, and his challenges about reaching women in a very conservative and traditionally bound society with low literacy and socioeconomic levels. So I suppose, would that be any sort of advice or a perspective that you can bring to the sorts of the challenges that Rajkumar, in a different culture, in a different environment, you might have, that you could extrapolate from your experience in Rwanda that could be helpful for the work he's doing?
Yeah, I think one of, I can respond that using my own experiences, the mistake I did, especially when I was training in US, you came with a big head, because you came from US, and you always go to see patients with a lab coat, white lab coat, and the stethoscope. But, you'll create different levels of understanding. The communication will not go on the same way. And I used to learn that it's really important to train peers to if you want to share the message to other people. Like if you have a group of women, why don't train women to talk to women on that area? If it's a society where men have more power, why don't you train men to talk to other men? So, and it's that context I'm using that approach. Now we have in Rwanda we have a very good program called community health workers. It's a people who are elected, in the villages, and those people, when you train those people, because that person is part of the village, it's part of the cell, it's part of those houses. It's really easy when they want to share the message. You train them and they go home, they go back in the community, and they share on the level of the language people will understand. But sometimes, I'm sorry for physicians who are here, there is nothing against them, but on my own experiences, but sometimes physicians are like on the pedestal and patient on this level, or the community on this level. And that's created, conflict in terms of communication. I think it's up to physician to go down to the level of patients, and even to go lower to the level in the community, to be able first to listen to them, second to adopt their languages, and third to adapt based on the solutions. So for Dr. Kumar, I think it's using, because I don't know the culture in India a lot, so it's see what will be, if you ask people what will be the best solution from you to share those messages among those women, I'm pretty sure you'll find the solution, because sometimes we try to think for other people, we try to think for them, we try to say, oh, this is your solution, and it may not work. So I think I can respond on that way. Yeah.
Thanks, Christian. There's also another comment. Maybe I'll ask. I wonder if David Ntizimira would like to ask that question directly. I see his comment on the chat. David, are you able to switch on your mic? Otherwise, I can read it. It's talking about strategy to scale up. Obviously, Christian, and I think that would be interesting. I think they're good lessons because you talked about your approach. You had a time of reflection, but obviously how your change in approach in which you are starting to looking at the community and mission. Hello, David.
Hello, thank you, Alessandro. Thank you, Christian.
Yes.
Lisa, how are you?
I'm doing well, David.
Yeah, so as far for background, he's my classmate, and I'm glad to hear he's sharing, you are sharing your experience. My question is, now I'm implementing some projects in West Africa, and when you look at the quality of service here, and it is really, really difficult to integrate this palliative care, I'd like to know from your experience, not in Rwanda, of course, in Rwanda, but you can share with us experience and give us some tips or some, how can we integrate? We can work with the Minister of Health from this country and to see how we can integrate or integrate the palliative care in this healthcare services, or the tips, how can we use, how can we start and improve. This is what I mean. Thank you.
Thanks, David. I maybe repeat because the connection was a little bit unclear. So I think that the question is about how do you, from that change in approach, that was your personal change in approach, Christian, how do you scale up, which is how, because to make the real impact, how do you scale up and ensure that that approach is integrated across Rwanda or across your district, and then start making real impact and reaching patients on a scale?
Oh, thanks, David, for the question. So I think we need, first we need to understand that palliative care is a multidisciplinary approach. It's not only focused on a physician, it's focused on the person, because if you treat, you can treat the disease without treating the person. But if you treat the person, of course, you'll be treating the disease. So it's two different concepts. So the second point is there is our part as an individuals, but there is a part as a local community. So one of the, I think the discussion I used to have with my friend when we was saying about leadership, and I told him leadership is more about character than accomplishment, than self-actualization. Leadership is more about character. Self-actualization, it's a consequence of a good character in leadership, not on the way around. So there is our part as a physician to change the attitude. And I remember, I think, I don't know if David remember well, I think we used to have one of our teacher who used to say, don't treat the pain completely, because pain is the big signal, is the best signal for you to know that your patient is alive. So if you treat completely the pain, so how do you know that your patient will be alive? So, you know, we went with that attitude until I was trained in palliative care. Then I just realized, no, we need to treat the pain completely. So that will start from me to change completely my attitude toward patients, my attitude toward the management and engagement. That is the first step. So the second step is about to continue to do advocacy. So it's one thing really, really important, advocacy. I've learned that from my experiences, because when you work in a hospital, you are so focused on technical issues. You need, you know, everything to be integrated, but you need also some resources. But sometimes, you know, patients, your position as a physician and all healthcare providers is to be the voice of voiceless, is to be the voice of patients at a different level. You will be to be the level to discuss and say, look, our patients need more morphine, our patients need codeine, tramadol, ibuprofen, paracetamol, our patients need this kind of services. Its advocacy is really, really important. So because you cannot integrate palliative care by your own, but you need support. at the government level, because you need to train people. One, it's education. Second, it access to more medication. And you have also implementation, which needs, the decision maker, policy makers, and also a group of people. But I think I can say on my own experiences, the first step came from your leadership to be the voice of voiceless, and to express that character of change, as long as you are providing a good care to the patients.
Thank you, Christian. I think that a few more comments in the chat box, but also before maybe I pick on one of them, I'd like to, because ultimately we try to draw lessons from Christian's story and his work in palliative care from sort of leadership more broadly. And I think I see a couple of points that come up from what he's saying in terms of the adaptation of certain guidelines and standards, and the fact that you need to be aware of the community, have that going lower, being aware of what the community think and how they're involved, and treating the patients as a person. So one of those sorts of implications is going upward, going systemic level, is what sorts of what are the implications in terms of when we have international guidelines and we need to apply them in local settings that have a culture that is totally different from the culture from which that particular guidelines has arisen. And how do we culturally mediate to ensure that those best practices are applied? I often hear about resource in cancer control. You have resource stratified guidelines that take into account the level of resources available in a certain community, so that they can apply a certain type of resource. Or maybe there is a conversation, there's a cultural equivalent in terms of having a sort of a cultural dimension, a certain dimension. How do we ensure that those good practices can get applied, and how do we do that at system level, and so that that can help? But also going a little bit downwards in the relationship between the physician and the patient. We all live in multicultural society. Physicians have their own medical professional culture. They deal with patients across many cultures, particularly in big cities, in all countries, the Western, the South, the North, or the East. So what's the level of cultural sensitivity that the physician needs to have when interacting with the patients, so that they create a real relationship? And we all know that physicians have a lot on the plate. So I think there are key questions in terms of drawing that cultural dimension, both at system level and as well as in the individual level, in the physician and patient relationship. So just a couple of comments on those, Christian, before maybe I'll give the floor to some other participants.
Yeah, just a quick comment. You mentioned something very important about how to bring those change, in a very systemic way, using policies, guidelines. But I think the first step is the language. I would like to ask the participant here to what the meaning of what's the translation of palliative care in the language, because we say about palliative care, the terminology palliative care, and in French it's soins palliatifs. But I would like to challenge all the participants here, if what is the translation of palliative care in their language. That is one of the challenge, because we use the terminology palliative care, end of life care, soins palliatifs, but in some of our language it's difficult to translate. People don't understand what we are saying sometimes, because the language is not adapted. So it's why I think it's really important to adopt, then to adapt, even it's a guidelines, protocol and everything, and making sure that it's really contextualized to the solution of the local people. So that is one comment. So the relationship between physician and patients, it's why I'm using that. I'm saying we need also to decolonizing, in terms of communication, because physicians are trained to treat the disease, but sometimes not to treat the person, because if you treat the person, it's totally different. And itself, I'm trying to do home-based care, trying to visit patients and family members, because I think we need some time to go out of the box and think differently. So, because to be a physician, it's a privilege and an honor to treat the disease, but we need to remember that it's not about the disease, it's about the person. So if you treat about the person, all details matter, including the culture, social culture, spiritual, physical, and social. So yeah, how to integrate that? So I've learned from my own experiences, and especially as you said, one important thing when I discuss with my colleague from a Western country is what I've learned is one day teacher, one day student. So it's not about we have the solution and we give you the solution. It's about learning best practice from one side of other. There is what we can learn from, and I learn a lot from US, but also I think my colleague from US need also to learn from some of our practice here. It's a mutual experiences exchange than one way to do things, because one solution cannot fit for all people.
Yes. Thank you, Christian. So I'm quite unconscious about time, and also quite keen to start to, rather than go deeper into the palliative care experience, go a little bit maybe higher and look at the implications, these cultural dimensions on leadership, about which I think was ultimately the theme. And obviously there's quite a lot of comments on the chat about how you went about the change in palliative care in Rwanda. And what I will do, we'll share, there are plenty of articles, and maybe I'll ask you, Christian, to share some of the latest examples of articles that sort of track what's been done in Rwanda and how that system has been put in place. That might be helpful for some of the participants. But I want to go step a little bit back and see this. Obviously, you've discussed about your decolonizing approach towards palliative care, and I know you've referred, although not literally here, to the Ubuntu philosophy that was underpinning that, because that's the philosophy of the communities you deal with. Has that, obviously that has changed the way you care and the way you palliate as a physician, as a practitioner. Have you embraced that sort of community philosophy in the way you lead, in the way you collaborate, in your way to, I know you founded recently ACREOL, in the way you designed that organization. Has that influenced you as in a way that you are as a leader? I'm curious.
Yeah, a lot. As I said, leadership, it's about character, and the character is rooted in different philosophy. So, and I know, René Descartes said, "I think, therefore I am." But Ubuntu is totally different. It's I am because you are. People are people through other people. So it's not about me, it's not about I, it's about us. So when I see a patient, it's more about the ecosystem. It's about the environment of the patient than the person itself. And I cannot isolate the patient out of his community. So that philosophy changed completely my perspective of care, because Ubuntu is really focused on humanness, compassion, care, and especially because we don't see ourselves, we call ourselves as a soul. It's more about we, it's about how my action can impact, your life, how your action can impact my life. It's about the interrelation between people and the human being. So, and also by setting the ACREOL, the African Center for Research on End-of-Life Care, when I came back from US, I came with two major questions. One is, how do African patients die? and how do African patients would like to die? Because I just realized from my experiences traveling around some countries, some people know how, how the patient die, but in most African countries, it's not clear, especially in research. Some research questions are not really adapted. When I was discussed with my colleague and said sometimes the research question is doing in Africa is not really adapted, because when you compare the palliative care in, let's say in examples, you compare in the US and you compare in Rwanda, what will be the value of that comparison? What is the research question can bring this change, in terms of policies and guidelines? Because it's different settings, we have different cultures, it's a different perspective. Even the philosophy of death and dying is totally different. So I think we need to adapt our research questions just to bring, a very concrete and adapted solutions. And also second, the African philosophy, it's really helpful to understand and to support not only the patient, but also to support also the family as well. So it changed completely my leadership way, and even my understanding how I can practice now palliative care. Because and the best example is, I've learned more from my patients than I teach them. So I'm like someone, every time when I meet a patient, I'm like a student. I need to learn from them, and I learned from them so much. Then I can be able to guide and to adapt the management of my care based on their need, not based on my knowledge and skills. And just I realized that the way people die can reflect how the society lives. So that would also depend on how it will be the philosophy. So if my philosophy is based on Ubuntu, where people are people through other people, so then I'm sure that our society, the way the patient will die, will be totally different and will reflect a more sense of humanity and dignity among our patients.
Thank you, Christian. And I think it's fantastic for the ACREOL. It's to start that journey in making sure that different ways of looking, and in this case, at palliative care and research for communities in Africa, it comes from Africa. So it's great that you set up that organizations and design it with this new approach in mind. I know we have a hot question, burning question from another former young leader of UICC. I think Kingsley would like to take the floor. Kingsley, are you here?
Yes, I'm here, Alexandra. Thank you so much for giving me the floor. And thank you, Christian, for the amazing presentation. I really love the fact that you have talked about like the power distance between being a leader as a doctor and the patient, and coming down to the patient's level. One question I wanted to ask you is, how do you approach spiritual care, given that, in Africa, there's a diverse, diverse forms of belief. We have Christians, we have traditional worship. How do you incorporate that in palliative care? And the second question is, how is palliative care funded? Is it a mix of government health insurance and out of pocket, or is it out of pocket? How do you approach those two? Thank you so much.
Thank you, Kings. I will answer by the second question. So the policy of the Rwanda government is integration. So because palliative care, it's a public health issue. It's not focused on a non-profit organization or a civil society organization. It's a public health issue. So it's why the solution from the government is to integrate palliative care in existing system, not create a parallel system. So, and then patients who are part of who need the palliative care services, they use the medical insurance, what we call the community health-based insurance or mutuelle de santé. So they can pay only 10% out of the pocket, and 90% is reimbursed by the government. So which in terms of universal access to palliative care, can give access to everybody in the country, which is, on my understanding, is the best approach. Instead of the program is based on, let's say, goodwill of some people at a certain place, certain site or location. So it's really helpful to make sure that all patients will get access to palliative care. So, and then you have a dedication. I think one of the major plan of the government is to move palliative care at the community level. So it's why the government plan to increase the number of community health workers, because the community health workers, they experience as community workers for TB, malaria, to reduce maternal mortality was so impacted and successful that the idea also to use community health workers to provide a certain package of palliative care at the community level, just to reduce also the bed occupancy rates at the hospitals. When you have patients who need palliative care, stay longer in the hospitals, and because they are fear to go back home and they can't get the same services. So I think when we'll get at that point, I hope it will be one of the best practices to share, but also to learn also from ourselves, because the community has more solutions than we thought. And so for the multicultural, multi-diversity, I think this is the beautiful part of palliative care. The more you are diverse, the more it's beautiful to provide palliative care, despite your understanding, perception, philosophy, because it's really important. It's a journey, and my understanding is palliative care is a journey. It's not a final point. Palliative care is not about end of life care. Palliative care, its approach to improve the quality of life of patients and family members. So it's a journey. So the more I've learned from my patients, the more I can adapt. So, and this is really one of the very funny example I'm using is, I know, Kings, you have a car. Well, I don't know, you live in US, but why it's easy to change a car with different system, and you find it more easy than, let's say, adapting our solution to different, patients. It's the same. So every time you get a new information, it's an opportunity to adapt. It's an opportunity to adopt and then to adapt. So there is no challenges. I think the challenge is when you take one solution and you want everybody to use the same solution to everybody. So that will become a nightmare. So if it's a Christian, why don't you train Christian to support Christian? If it's a Muslim, why don't you train Muslim to support Muslim? If it's a traditional practitioners, train them to support other traditional people. So then that will reduce your burden, instead of saying, oh, everybody need to, as I saw a small picture on Google, it was all animals were there, and in the fair of the exam, the person asked every animals to climb the tree, and only the chimpanzees was lucky because this is easy for him. But you can ask an elephant or a hippopotamus to climb the tree. So we need to adopt. It's a long journey, then to adapt, depending different circumstance and depending different situation. That is the best way we can, because my understanding is global is local, as local is global. So there is we cannot connecting at global level without connecting identities. So we need first to connect identities at the local level, then we'll be able to connect at the global level. So there is no global without local. And there is no local without connecting identities. So the more we have identities, different identities, the more we'll create a local community to the global level.
Thank you.
Thank you so much, Christian. Thank you so much.
Thank you, Kingsley. And I think that we entered the final 10 minutes. I'm conscious of that. And I think that that point that you raised, Chris, about global is local and local is global. And it's a little bit like the key that we're trying to draw out of conversation. Obviously, palliative care seems to be, because of its perception and its links to end of life that often are taken in community, it's a flashpoint for cultural sensitivity, because end of life is so linked to a particular culture. So I think drawing this examples from palliative care, or how cultural sensitivity is important in order to ensure the best care for patients. I think what we're trying to do there is to extrapolate that, and then to look at the across the cancer control continuum. Palliative care might be a flashpoint for that, but this needs for cultural sensitivity is actually important across the whole continuum. And I think it is important at system level, as you mentioned, how you apply international guidelines to different situations, how global become local, but also at individual level in the relationship that physicians might have with patients from across communities, and how that will feed back into the system, and how local become global. So so I'd like to maybe draw out a few final lessons, if we can, Christian, out of this conversation. Maybe what would be your sort of takeaway messages from this needs of cultural sensitivity that we've sort of described around in palliative care, but it could be relevant across the whole continuum of cancer control? What are your takeaway messages that you like to leave our participants with?
Yeah, I think one is, as I said before, the way people die can reflect how the society lives. So it's really important, on my sense, on my opinion, to really now it's time to integrate social culture, really not as, part of like the fifth wheel of the palliative care program, but as one of the really important, elements in the approach of the patient. So then we'll be able to define to the level where best practice could be exchanged. So I think we need, for the better of our society and for the equity and diversity, we need to take into account those critical elements. And also, as I said, one day teacher, one day student is to learn each other from our different experiences. So there is no a perfect solution. There is no perfect failure. So I think the most important thing is just to learn, because at the end of the day, when you help the patients, it's always a winning game. It's always a winning game, because you'll never fail on that context. So I think that is my takeaway message for the participants. But of course, I know that most participants have a lot of experiences, but I think we have now a way to want to change. As I said, as a leaders, we need to change. And I'm always discuss with my oncologist friend and said, when you mention about the diagnostic of cancer, you start by the organ and you finish by cancer. You said liver cancer, cervical cancer, prostate cancer. But when it's about a patient, you say cancer patients. Why you start by cancer to identify your patient? Why don't you say it's a patient with cancer? So it's about all these simple things. Can as a leader, we need to make starting from us, then really impact others. So yeah, I think though we're still learning. It's a long journey.
But as you say, once a learner and once a mentor, and it's a continuum cycle. Well, in terms of, I feel why this conversation is important. This is just the start of a conversation. Leadership is ultimately about influencing people. Is about driving behavior change sometimes, or bringing people together, or mobilizing community towards a common goal. So, and that cannot truly happen in any meaningful or sustainable way if we don't tap into people's beliefs, people's ideas and customs and behaviors. So this sorts of, which is about the culture, where they're coming from. So meeting the person where they are. And so this idea of bringing this cultural sensitivity to the way we lead. Obviously, we can't know all the culture of the world, but we can be sensitive and aware about how different communities might receive messages, might behave or believe in certain things, and adapt our sorts of behavior accordingly, or using cultural mediators when we operate in a setting that we're not aware of. I suppose these are all sorts of important lessons to me as well.
Yeah, and then another important point is, which is really interesting in palliative care, is someone asked me, how do you do to increase followers? Because as you are a leader in palliative care, how do you do to increase followers? And I'm sorry, I've never been, I don't have followers because I'm still following the patient. So the leader is the patient. So when I'll become a follower, so it's completely different. It's the task shifting. It's a paradigm shift where the leader is more patient than us as a physician. So I'm still following the patient because they are still the leaders. Maybe if I become a patient, then I'll be a leader on that sense. But until now, I think the patient has more leaders than us because we learn from them a lot.
I think with that particular lesson, the leader is the patient. I think we couldn't end it on a better note, because I think ultimately this conversation is about ensuring better care for patients. And I might just close with a final invitation to all of you all. Thanks for staying on this call for the whole hour. Obviously, this is we're discussing about different approaches and different communities, and obviously what best place this year we will finally be back and having a World Cancer Congress here in Geneva, where the diversity of approaches and the diversity of communities will be showcased, and where we can finally meet in person and learn from each other. So if you can see, and it's an in-person banner behind me, because slowly going away from the virtual world. So hopefully many of you will be able to join us as well and continue this conversation in October at the World Cancer Congress, where we hope to learn from many more inspired leaders and learn from patients about how they go about ensuring cancer control and care across the world in a culturally sensitive way. Thank you, Christian. It's been a pleasure talking to you. Thanks, everybody, for staying with us for the hour, and hopefully we'll see you at the next session in the series. You might receive a quick survey when you close this, when we close this meeting room. So hopefully do feedback, any suggestion for a certain topic or an aspect of leadership you'd like to hear in these virtual dialogues, and I hope to see you soon. Goodbye.
Thank you. Thank you. Goodbye.